Well, hello, and welcome to another episode of Longevanity, where we look at the combination of both living your best life physically in how we're aging, as well as how we look, so that we look great, feel great, and really can enjoy the time we have. So, my name is Dr. Amber Bocknek. I am actually a physician up here in Ontario, Canada. And I'm coming to you live from the office where we like to focus on a lot of health and wellness topics. So, today, what I really want to focus on is hormone health. There's a lot of talk out there and more information that's coming available all the time. And I think it's such a key topic. Before we dive in today, it's again very important for everybody watching this either live or on replay that this podcast is intended to provide you with education. It is not a substitute for good personalized care from your own primary care practitioner, and that the information we talk about here today or recommendations are not intended to diagnose, treat, prevent, or cure any disease, but rather give you tools, set you up so that you can have good, meaningful conversations with the people you go to, know, like, and trust for your healthcare. So, very important that you take today for what it is, just some good educational content, and please make sure that you run all treatment decisions past your own primary care provider who knows your health the best. So, with that, let's talk about hormones and perimenopause and menopause. So, this is definitely an up and coming topic. It's definitely a topic of interest to me. My demographic, I'm the conventional middle-aged woman. I'm a Gen Xer in my mid-50s, and so of course I'm walking this journey as well. And a lot has changed. And what's very interesting is I look at it now at this stage of life from two perspectives, from the physician perspective as well as from the patient perspective. So it definitely sort of fills out all those little details for me. Now, speaking with my doctor hat on first, I have been in practice now. I graduated way back in 1998, so we're going going a ways back now, and that was pre-Women's Health Initiative. So just a little bit of history here. Hormones have gone kind of full circle in how we look at them and how we approach them. So in my early days of practice, we were very pro hormone. I prescribed it widely in my office. I wholeheartedly agreed with it. It was already known back then that there were some definite positive health benefits for women, that it again slowed down some of the degenerative changes of aging, such as it slowed down risk of development of cardiovascular disease and bone loss and brain fog and cognitive things. We knew this back in the late 90s and early 2000s. But what happened was the way we administered the hormones back then, the type of medications and synthetic things we were using in the role of hormones, and note the wording there, in the role of hormones. In North America, we weren't doing a lot of actual direct identical human hormone administration. We were using medications that were similar, but not identical. And so the way we gave them, what we gave, ultimately, now 20 plus years later, we understand that the methodology was the issue, not actually hormones themselves. So in 2002, here was the Women's Health Initiative, which was a fairly large study, first of its kind, and it raised a lot of alarms over risk. And so some of the risks they identified were that of breast cancer. What's interesting is that that's one of the big headlines from back then, was the breast cancer risk. It was widely publicized through the medical media and also layperson media, and that left quite an impression. Now, cancer is something, of course, to take very seriously. I actually am a breast cancer survivor, so it again also rings very true, near and dear to my perspective on things. But what we have subsequently discovered is that the risk was more likely related to the type of substance we were administering in the place of, not the same as, natural progesterone. And these are called progestins. So we gave progestins back then. They came under a couple of different brand names. They were commonly used. I prescribed them myself back then. We didn't know any better. And the progestin component is actually what we have affiliated with the increased breast cancer risk. Interesting, what never got a lot of publicity back in 2002 when this emerged is they had different cohorts of people, different groups of people. And so there was one group of women back then, we didn't give progestins or progesterone to women who had had hysterectomy. Mistakenly, again, another kind of thing I would do differently in practice today than what we did back then, but we looked at progesterone's role post-menopause as being something only to protect the uterus if you had one. So if you had had a hysterectomy, it was not required. So again, it's not what I think today, but that was the common thinking, over 20 years ago. So when they looked at these women and they subdivided them into the different categories, so women who had had a hysterectomy for whatever reason, who were not receiving progestins versus women who still had a uterus and were getting both the estrogens and the progestins, they found that the increased risk in breast cancer was in the progestin group, not the estrogen only group. The estrogen only group actually had a slight reduction in breast cancer, a reduction. And this never hit the media or any of the attention at that time. So the way we reported and interpreted that study was erroneous. And we basically threw the baby out with the bathwater. Again, hormones weren't the enemy. What we were doing, what we understood at that time to be hormone replacement was actually, it was a little bit wrong. The other issue that came out with that study was on the estrogen side of things. And there, with those estrogens that we prescribed back then, and I can tell you firsthand, being in practice in that era, the main estrogens we used were not human estrogens. They were acquired through horse urine. And so actually there were two different brands that we used. And you can actually now, in retrospect, you look back at it and you're like, holy, how did I really not kind of pay attention to that? I knew it was from horses, and as we all did, but it again didn't quite make the link that, well, humans may not need everything horses need. So one of the brands was called CEE, conjugated equine horse estrogen, and the other one was Premarin, pregnant mare urine. So this is where we got our estrogens from. And so part of it was we were giving estrogens that were not exactly the same as what humans create. And the second bigger problem, I think, was that we were giving estrogen by mouth. The issue with estrogen specifically, not with real progesterone to be differentiated from progestins, was estrogen by mouth goes through digestion like everything else does, like every other oral medication or food. And so in this process, any of the estrogen you take and you swallow goes into your stomach and then into your intestine. In your intestine, it needs to cross from the inside tunnel of the intestine actually into your body. And as it does so, the blood supply that supplies the intestine, the next place that it goes to is actually the liver. And the liver's job is to process things, clear things. And so when it got this high hormone load, it started to make a lot of metabolites. And some of the things that happened in that process increased coagulability, the way your body clots. And so we saw an increased incidence in blood clots. Blood clots can be bad when they happen at the wrong time and in the wrong way. They can lead to embolisms that can cause pulmonary embolism. So clot that goes to your lungs, that can interfere with your ability to exchange oxygen and can kill you. Or again, clots that could go to the heart, the brain. So there were heart attacks, strokes, all kinds of different things associated with these clotting problems, which now again we attribute to the way we were administering it. When we do things now using human estrogen as opposed to horse, and we use it transdermally or transvaginally, so not by mouth, we don't have that same incidence. So in these bioidentical or body identical human equivalents of estrogen given non-orally, we don't have those issues. So there are proper ways to do this that can be quite safe for most people. So this is something, again, that kind of brings us and brings all of the hormone replacement back to the forefront. The very unfortunate thing that happened, if you look at that time frame, 2002 was, again, just a little over 20 years ago. there's a whole group of women, basically, again, if I look at my own age and sort of relate it to me, sort of my mom and my auntie's age, that whole cohort of women, the boomers who are ahead of us, they really did not get offered hormones in a meaningful way. And so we see much higher incidences in this population who were denied hormones because of the concerns post Women's Health Initiative. We see much higher risks of osteoporosis, falls and fractures, frailty. We see more cognitive decline, more dementia, more people who are needing long-term care, nursing home care because they can't function, more cardiovascular risk. So again, there's been a big loss to the population in health because of, again, some of what happened after that. So hormones can be something to be explored. And this is a conversation piece. If you've heard a lot of negativity around it, this is where you maybe want to go back to your care provider and start talking to them if they have a lot of apprehension. You know what's very interesting? My husband is a veterinarian. And there was a study on vets, and I think this holds true to pretty much anybody in any profession, but they looked at veterinarians as far as prescribing and practice habits. And what they wanted to know was, what is the single biggest variable that predicts practice habits and prescribing habits? And you know what it was? It was the year they were trained. And I think about that, and it really, if you look to help better understand why there's so much variability in opinion in medicine, and why sometimes you still see a lot of apprehension around hormones, is the year we were trained or came into practice. So for those of us who were trained and before the Women's Health Initiative, came through the Women's Health Initiative, or in the first decade after the Women's Health Initiative, I think we've all drank the Women's Health Initiative Kool-Aid, if you want to call it that, in that we are indoctrinated, and we really, that fear aspect really permeates anybody who practiced through that time frame. And so it may take a bit of time before the newer, more updated information has the same mental weight as what that fearful content did from all those years ago. Everybody who goes into this profession takes the Hippocratic Oath, above all else, do no harm. So again, when you hear about types of treatments and other that have a history of causing harm, it creates fear. It's the opposite of what anybody wants to do. But the big thing is to be a critical thinker, to stay current with the literature, to go back and revisit some of these things, because although those things we did in practice were incorrect, and it's very good that it was discovered, that's good that that happened. What's not good is that we've stuck at that point and we haven't kept evolving with our knowledge and our level of care. So if you find when you go to your primary care doc or nurse practitioner or OB-GYN or internist, and you find you get a little bit of pushback, it may be because they were trained and came through that era or shortly after, and so they're hanging on to that. So sometimes I would encourage you to be your own best advocate and talk to them a little bit about exploring some of the subsequent studies. There's actually been a fair number of studies that have come out since then that show all the benefits. And when we remove some of these variables, so for example, the Europeans' prescribing habits were very different than the North Americans. The Women's Health Initiative was a North American study, whereas the Europeans were using a lot more body identical or bioidentical hormones, and they were giving them non-orally when it came to estrogen. It's not the same issue with progesterone, just in case you're out there and you're listening and you're worried because you take an oral natural progesterone or, again, a body identical oral progesterone. Progesterone's metabolite is actually quite helpful. So it's a different scenario, but specific to estrogen. So the European studies that have come out and subsequent ones since then that have since followed up, and when they've crunched all these numbers and they've tried to filter out progesterone versus progestins, because a lot of times they get lumped together. But with all this teasing out of data and looking at data, really scrutinizing what was used, how it was given, we're actually seeing loads of benefit from it for most people. So again, this is something to perhaps reconsider. The other thing to talk about that often is missed, a couple other things while we have a bit of time. One is that humans, all humans, create the same hormones. And I'm talking about men and women, gender at birth, make the same hormones. We make estrogen, women and men, progesterone, ditto, testosterone. Yeah, ladies, we have testosterone too. We just have a much smaller amount of it, usually about a tenth of what the guys have, and something called DHEA. So these are the other components here that are very important. And so the whole hormone picture includes all of these things. It includes, for women, again, speaking specifically to women today, it includes estrogen, progesterone, testosterone, and DHEA. So again, a full comprehensive panel would be to look at those levels. They are measurable in the blood. So that is something that can be measured. It can be done through conventional lab testing here in both Canada and the US. So it is available. You just need to ask for it. And these are hormones that can actually be supplemented. They just need to be given in an appropriate way that does not induce harm. Again, certain things should not be oral. So specifically, the two hormones that are best not ever given orally would be estrogen and testosterone. So estrogen and testosterone have similar issues. So those things should not be given orally. There are other ways, of course, to give them, again, through creams, through patches, vaginally, injectable when it comes to testosterone. So there's lots of different methods, but just not oral. DHEA and progesterone can be given orally or topically or transvaginally. So again, options, but they're important things to consider. So all of these things work together to create health for us and help keep us youthful, as well as try to prevent some of the disease or slow the progression of some of the age-related diseases. You know, it's interesting. There's two very different schools of thought. So conventional thinking is that, you know, we get older, and so because of that, our hormones fall. It's just natural. It's part of life. And to some degree, that's true. But there's a counter to that as well. The other way to look at it is our hormones fall, and then we really begin to age. So to try to keep more optimal health, if we keep our hormone levels more optimal, we may find that we can slow down some of the changes associated with aging and mitigate that somewhat. So that is more the functional health approach. I'm more in that latter category now, as I've sort of, you know, experienced a little more of life and become very interested in this topic. It's funny what you get interested in as it starts to happen to you. So again, this is sort of my school of thought is if I can keep my body's systems functioning more optimally, I will age better and I will have a better quality of life. Now, don't get me wrong, it's not that I don't want to live longer, but I'm not trying to delude myself that this is about longevity or necessarily increasing my lifespan. If I'm healthier, it is logical to assume that most likely I will live longer, although again, there's no guarantees in any of this for any of us. But I'm really interested in my health span. So longevity versus health span. Maybe at first they sound kind of similar, but they're actually very different. So longevity is just the number of days, how long you live. I'm interested in that. Of course I am. But what I'm more interested in is health span. Health span is how long I'm healthy and functional for. I want health span. I really want to have quality of life. If I'm on this side of the daisies, I want to have a life where I have good cognition, where I'm not frail, where I have mobility, where I can go out and enjoy the things I have, and then someday, you know, kick the bucket. But in the meantime, I want to have lots and lots of quality. So I think health span for me becomes the most important thing. And that's a combination of many things. So again, hormones are part of the equation for sure. And I would encourage everybody who is sort of coming into, even in perimenopause, there are some things that can be done to be helpful. For example, helping with progesterone in particular. Progesterone is one of those first hormones that kind of drop off, and that really affects how you feel, how you sleep, and just some of the things with your body's metabolism, etc. But that is something that can be supplemented during perimenopause before full-blown menopause. But yes, hormone health is definitely part of it. Good nutrition. We live in a fast-moving, fast food, processed food society. Again, one very fundamental thing to consider is what are you fueling your body with? So really looking, just the simplest thing is really try to steer clear as best you can from the highly processed foods. So whole foods, less processed, colorful foods, more Mediterranean diet, modified, of course, for your own specific dietary needs, or again, have a quick chat with your own primary care provider about it. But quality food in, quality in equals quality out. But again, nutrition actually really is important. Sometimes with our very modern farming practices and the way we handle soil and food processing, some of our food is not as nutrient rich as it was before. Sometimes careful supplementation, like a high quality third party tested multivitamin, may even be helpful. Again, just make sure you run that past your own care provider first to make sure there's no reason not to. And another big factor is sleep. Sleep is when your body regenerates and heals itself. And I think a lot of times when we have many demands on our plate, we deprioritize sleep, or we lower it down the priority, and we're not getting enough. How much does the average adult human need? Between 7 and 9 hours, and at a very consistent time. So again, improving your sleep and trying to be very regular about your sleep and protecting your sleep is a very important part of trying to keep your body healthy. There's lots of tools on the internet. If you search up sleep hygiene, you can find some things that can really help guide you. And then lastly, just stress management and balance, trying to stay connected to those around you. Don't sweat the small stuff. Try to let that go. Stress can also be very harmful and very taxing on your body. So again, you want to do your best to try to mitigate that, set some healthy boundaries. It's a new year as I'm doing this today in early January. Maybe it's a good time to take a little bit of personal inventory. And if there are people or situations in your life that really don't bring you joy, that bring a lot of drama or toxicity with it, maybe that deserves a little bit of a reassessment as to why do you necessarily need to be engaging in that anymore? Because again, sometimes removing even one of those very difficult situations or setting up a healthy boundary there can really help reduce your stress. And then just simple stress management techniques. Again, if I don't have opportunity today to go into full detail, but just looking at some breath work. Some of the things we do with deep breathing. I know it sounds really fluffy and foo-foo, but actually there's a physiologic thing that happens when you do some of this deep belly breathing. It actually activates your parasympathetic nervous system, your rest and digest nervous system, which is very calming, and it can actually make you feel better. So if you're stuck and you can't modify those more challenging relationships and you need to be there in that space, then maybe you can do some breath work and some box breathing and other breath techniques before and after you go into those situations, just to help really reduce your body's response, because you do have a physical response to that stress. Ratchet that down a little. So hopefully some of those things will be helpful. And please feel free to watch and join us here. If you'd like more information about some of these topics, here's the QR code for our website. So if you scan this, it'll bring you into our website where you can get more information. And if you enjoy what you're seeing here, I would really appreciate your subscription to the the podcast, we're really trying to put out meaningful, well-vetted educational content. So the more, again, engagement we have with those of you who are interested in this, the better. You're welcome to message me with topics and questions and things you'd like to see spoken to, and I would be very happy to include that in our podcast. We're going to be having some interesting guests starting soon too, so I'm hoping you'll join us for that. So that concludes today's episode. Again, everything spoken to here today is really not meant to be medical advice. This is educational advice to stimulate conversations with your own care provider who knows you the best, knows your personal health situation, and can help walk this journey with you. Until next time, thank you for watching, and it's been a pleasure to speak to you today. Hope you all have a wonderful day, and bye for now.